Hello, I'm Dr. Jay Noreen, and this is Health Talk. There's more attention today to heart health issues than really ever before. The Cardiology Center of Appalachian Regional Healthcare System welcomes, to the credit of the community, a new cardiologist, Dr. Donna Denier. Welcome to Health Talk, Donna. We're really pleased to have you here.
Thank you very much. It's my pleasure to be here.
Well, you know, our audience is the general public, and often a lot of App State students watch this program, particularly those who are interested in health professions. And so if you're willing, it'd be interesting to all of us to hear a little bit about cardiology and the nature of your practice, just in general terms.
Well, cardiology is a practice that's more important than ever because, as we all know, heart disease is so prevalent in the United States and around the world. In cardiology, what we focus on is preventing heart disease in patients, and those who are at risk, we can diagnose them and treat them as early as possible. One of the things that's exciting about it is that it really combines the love of science and the love of people. So if you have an academic mind and you enjoy science and you love ongoing research and therapy to help people, but you also love the day-to-day interaction with people, it's the perfect thing.
Well, you know, as I say, there are a lot of people out there who have their physicians but seldom get a chance to find out, you know, how did they get into this field? It would be interesting, and particularly to students and interested in health professions, to hear, how did you decide to go into medicine, and how did you pick internal medicine and then cardiology?
Well, for me, it was a little bit of a process, and you know, like many students coming out of high school, I wasn't sure what I wanted to do, and I had an interest in science, and at that time, I thought to begin by going into nursing, and I started with nursing, and through my training in nursing and my dealing with people and patients, I realized that I wanted even more, and I really wanted to delve in deeper. So I decided to go back and go to medical school. When I was doing nursing, I was working with cardiac patients, and I loved cardiology. Cardiology is just a rapidly moving, fast-paced, you know, atmosphere, and an area where you can really impact people's lives. Mm-hmm. So I went back and I took all of the prerequisites for medical training and went to medical school. While I was in medical school, I thought about whether I would want to do the same specialty again. Do I still want to stick with cardiology or try something new? And you know, I thought about a few other things. That surgery is a lot of procedures, and internal medicine is really the diagnostician, you know, the person who understands all the depth of the medical conditions. But cardiology kind of put those two things together. There are a lot of procedures involved in cardiology, as I mentioned, a lot of ongoing research, and it was the perfect thing. So I decided to stick with it.
Well, I can relate to that. I'm a general internist, and I've often been a little envious of cardiologists and others who are real interventionists, so I can really understand that. Well, you're new to Boone, to the region.
Yes.
And, you know, those of us who live here love it. What made you decide to come and start your practice, or add to your practice here in this region? It's a real benefit to us, but what made you decide to come to Boone?
Well, I first fell in love with Boone about 6 years ago when one of my sons attended App. Yeah. And I came to visit him when he was living here, and I immediately fell in love with it. It was like no place I had ever seen before, truly God's country. I stepped out of my car at night, and it was the first time that I had the ability to count every star, and that just made me fall in love with it. I grew up in New York and practiced in New York for 17 years before coming here, and 3 of my 4 sons actually moved to North Carolina before that, they've been down here for almost 10 years, and they loved it and decided never to come back. So I decided to come and join them, and along with my 15-year-old, and we love it.
So the kids educated Mom about the quality of life in this region.
Absolutely.
Well, tell us, if you would, about the cardiology center at App Regional.
Well, the cardiology center is a wonderful place because it provides the opportunity to give full care to patients and a full scope of cardiology services. In the office, we see patients either who come because they feel that they're at risk for cardiac problems, or they've had a symptom that they're concerned about, and they would like to get that evaluated. They're very often referred by their internist or possibly by a surgeon who wants to make sure that they're okay before undergoing a surgical procedure. We have the ability to do all cardiac testing, stress testing, echocardiography, even cardiac catheterization. Mm-hmm. And because of the close proximity between the cardiology center and Watauga Medical Center, patients can be seen in both places, and there is a very good interface between the two.
Mm-hmm. I noticed in your CV that you have some very significant experience in nuclear cardiology and echocardiography, and I know you mentioned that that's part of the center. Can you describe, kind of for the general public, what is nuclear cardiology and how does echocardiography, how does that work?
Well, nuclear cardiology is used for stress testing, and there are a number of different types of stress tests that we do. The basic concept of stress testing is that it's to bring out any underlying coronary artery disease that may exist in a person who has some symptoms that they're not sure whether that chest pain is due to the heart or it may be caused by something else. Patients sometimes are confused about the terminology because we call it stress testing, but it really doesn't have anything to do with stress in their lives. It's really just that what we do is sometimes you will not get a symptom when you're at rest, but by providing a little bit more stress to the heart, just by basically exercising, that may bring out something more serious. So nuclear imaging adds to that. It adds to the ability to pick up a blockage if one exists, because it shows the blood flow to the muscle of the heart, and we're looking at that with nuclear imaging to see if there's an area that looks like it's not getting enough blood flow. That can increase the sensitivity of the test and make us aware of someone who might be at risk for a heart attack in the future. Echocardiography is also used for the same thing, same purpose, but it's used in a different way. What echo does is looks at the motion of the wall of the heart. So when a person has a blockage in the artery and they're not getting enough blood supply to that area of the wall, that wall will stop moving in a normal way. And we have a person, we take echo images of a person at rest, then we have them exercise, and afterwards echo again. And echo is really just a sonogram of the heart. Mm-hmm. There's no injected agent or anything like that. But we can see that if there's a new wall motion abnormality after the person exercises, that would suggest that there's a blockage.
Well, I think for sort of the general public out there, it's an imaging technique. It's something that shows you by the use of sound waves, basically, the wall of the heart. And it's, from the patient's perspective, it's fair, I think, to say that it's a pretty easy thing to do. It's an easy procedure, relatively speaking.
Patients love it because it's easy, it's painless,
yes,
and it's usually pretty fast.
Yeah.
Where the nuclear imaging takes like 3 or 4 hours,
Yeah.
the echo stress test only takes about a half an hour.
Yeah.
So they like that one better.
Yes, understood.
It's not for everyone, though.
Yeah. Well, heart disease, of course, is a very far-reaching and common problem in our population. How common is it? Can you give a sense of how frequent is cardiovascular disease, and what are the most significant of the cardiovascular diseases?
Well, heart disease, cardiovascular disease, which encompasses heart disease and stroke, is the #1 killer of both men and women in the United States. Heart disease alone affects 1 out of 3 men and 1 out of 3 women. It actually takes more lives than all causes of cancer combined. And this is particularly significant for women because years ago it used to be thought of that it was a man's disease. And women now have started to come to understand that even for women, 1 in 3 women will die of some form of cardiovascular disease. It's widespread in the United States, and it really covers all ages as well. There's no set age for heart disease, although the risk of developing heart disease increases as we age.
Well, you know, I think that in the general public there is a lot of publicity about cancer and about heart disease, and I think the point you made is important for the public in general to know, that it is the leading cause of death in men and women. Coronary artery disease, the leading cause across the country. And so what people can do to prevent is very important. I know that's one of your major areas of focus is prevention of cardiovascular disease. Can you, sort of in general terms, give us an idea of what is your typical practice? What's a typical day? What are the most common things you see?
The most common thing is some form of concern about chest pain. Patients come to talk about that, and it can be the entire realm of chest pain. But if a person feels that they have a symptom that's new, something that they're concerned about that they didn't have before, they want to check it out. And that's a great thing, because that shows that people are now more aware about cardiovascular disease, and that symptoms of chest pain are not normal and they should be evaluated. What we do is we try to determine what is a person's risk, first of all. What is their risk for cardiovascular disease? What is the symptom like, and does that symptom follow the pattern that we're looking for to see whether it really could be caused by the heart or something else? And then we plan testing to further evaluate that and come to a conclusion. And based upon that testing, then put in place a plan for treatment and further prevention of anything beyond that. Patients come for other things as well. A lot of times people feel palpitations. They may have an arrhythmia of the heart. That's another one. And like I said, sometimes they're not even having a symptom yet, and they just know that they're at risk, and they just want to come and get ahead of that and make sure that it never happens. So these are the most common types of patients that I see.
Well, now, chest pain is something that, you know, a lot of people, families experience a family member who's having chest pain, and it's very difficult to know, is this serious, is this not serious, what does this mean? How would you, a spouse says, my husband is having chest pain, and you know, I haven't been able to convince him to check it out, but what kind of chest pain would be a very strong signal that you better check this out? Well,
the most common scenario that you see, like in the textbook, is mid-sternal chest pain right in the middle of the breastbone. It's not always left-sided, but it can radiate towards the left side of the chest. It can radiate up to the jaw or the left arm. It sometimes goes down the left arm. And it's usually associated with shortness of breath or breaking out into a sweat, sometimes nausea, vomiting, or lightheadedness. All of those symptoms. If you had all of those symptoms, and if that symptom occurs during physical activity, that's pretty classic. Now, that being said, the symptoms are not always classic, and particularly for women, those symptoms are sometimes different. In women, more often they present with shortness of breath, new fatigue where they were able to do all of their chores and activities of daily living, and now all of a sudden they have to sit down, they have to stop sooner. They may notice that nausea. Sometimes it's right-sided chest pain. Sometimes it's not always associated with activity. Sometimes radiating to the back. But what I would say for evaluating chest pain is never be afraid to come and have chest pain evaluated. It doesn't have to follow the book. I have had patients come to me and say, you know, I feel really silly coming here with this symptom because it's in my right arm, it's not in my left. Or, you know, there's something about it that they know is not the classic.
Yeah.
But anything that's new, any new symptom, or if you're planning to start an exercise program and you've never done it before, even if you don't have any symptoms, it's a good idea to check yourself out before you begin an exercise program.
Now, what other things cause chest pain? What are the other possibilities for explaining chest pain?
Sometimes it turns out that it's not the heart. Very often it's a GI origin, meaning that it's related in some way with the digestive system, either irritation of the esophagus caused by reflux disease or a spasm of the esophagus. That's very common. Sometimes patients will tell me that they lie down at night and that's when the pain becomes the worst, and that's typical for pain that's caused by a GI cause. There can be musculoskeletal pain that can be caused by the small joints between the ribs and the sternum, and that one is very common. But you know, there are a lot of other things, even pulmonary. Sometimes people with asthma will develop pain with respiration, and they're concerned that maybe it's the heart.
Now, can you give a sense of when one should be concerned about one's spouse or one's father or whatever, in terms of A, intensity of the pain, and B, duration of the pain?
Well, any pain that doesn't go away should be evaluated immediately. And the worst thing to do is to get on the phone and try to make a doctor's appointment at that moment. If someone is having chest pain at home and that chest pain is severe and it's not going away and that person looks very ill, you should always call 911. That should be immediately evaluated, and there's no harm in going to the emergency department and having an EKG done and have it evaluated. The appointment can come later. So severe pain, we always rate things on a scale of 1 to 10. So if it's in the higher range, 5 or greater, and it's not going away, I would suggest getting to the emergency room.
So err on the side of caution. Better to get there when it's not serious than to not get there when it is serious.
Absolutely.
You talked a little bit about stress tests, and you know, most people haven't had a stress test. In expectation that I'm going to have a stress test, how would you explain what the experience will be like to a patient who hasn't had one?
It's really very painless and should be fearless. You'll come for the appointment, and you know, the nurses and the staff will talk you through it and make you feel very much at ease. The hardest part for the guys is usually that they'll shave little areas of the chest to get the hair off because they have to put the electrodes on and get a good picture. So sometimes that's the stress. But after you're hooked up on a monitor, you're asked to step up on a treadmill, and it's basically just exercise. Very often patients will express fear about that because they're afraid, oh, we're going to make you run until you fall down. I've heard that expression many times. I don't know who spread that bad rumor, but we don't do that. Usually it's just regular exercise. And what I always tell people is it's so much better to exercise to that degree when you're surrounded by a group of professionals and you have a heart monitor on and we can do something to help. If it does bring out a symptom, this is the time to do it, rather than when you're out mowing your lawn or, you know, doing something physical where no one is around. you'll usually walk until we can get the heart rate up to 85% of the maximum predicted. And, or if you develop a symptom, chest pain or shortness of breath, and then we bring it down gradually and let you recover, and then you're done.
So it's actually I've had one myself, so I can say this, it's really a pretty easy thing to do.
It is.
And it's very carefully monitored.
Right.
Very safe.
And very valuable.
Yes.
You know, it really, it tells us so much information. We can tell, first of all, what your exercise tolerance is, which is helpful. It tells us whether or not your blood pressure elevates normally. And your blood pressure should go up when you exercise, but in a normal pattern. It also tells whether your heart rate responds normally or you develop any arrhythmias with exercise. All very important pieces of information. And the most important, of course, is to see whether or not you may have blockages in the arteries.
Now, in terms of the general advice, when should a person who is asymptomatic and doing well have their first broad evaluation of their cardiovascular status? What do you recommend?
Well, I think the first evaluation really should be that a person establishes a good relationship with an internist, and I really think it starts there, and that's the most appropriate thing. You know, as a good internist, you know, you're going to take a good history from that person and establish what their risk factors are. Take and examine the person. If someone has risk for heart disease, then the next step would be a stress test. But we don't routinely do stress tests for patients unless there is some particular risk. What we use the stress testing for is those middle patients, people that you can screen out and you're pretty sure that that chest pain is not from the heart. They don't necessarily need a stress test. Someone that I described before that had the typical sounding chest pain probably should go straight to the cath lab and have an angiogram. But it's the people in the middle that have a story that fits a little bit. They have a couple of risk factors. That person should have a stress test. And as far as age, as I mentioned, anyone who's at any age, if you're going to start an exercise program that's vigorous, that you've never exercised before, a stress test is not a bad idea before that. We consider, like, if you haven't done it before middle age, or 50 is the new middle age.
Yes, yes.
That's the magic number
There
to
we
start
are.
reevaluating your health and think about it.
Now, I know that you have a very strong emphasis on prevention. What is your kind of set of advice and recommendations for the average patient on what they should do to prevent heart disease? What are the main issues?
Well, this is definitely my area of interest, and what I advise people to do is to evaluate their status of their risks. That's the most important thing, is to know your risk. And we divide those risks into those risks that you cannot change and the ones that you can. The ones that we cannot change, obviously, is our age, although we wish we could.
Yes.
and sometimes our genetic makeup, sometimes you wish you could be born from a different family, but we cannot. But the genetic risk is there, and as we age, the risk goes up. So if you know that you have high risk based on those two things, the other things to know is know what your cholesterol level is. Sometimes high cholesterol will run in families as well, but knowing what it is, knowing what the ratio is, the breakdown of that ratio. Make sure that you have a high level of the good cholesterol, the HDL, and a lower level of the LDL. Sometimes just exercising and losing some weight and eating a little bit better is enough to make that adjustment. It doesn't always require medication. Diabetes can very often be prevented by keeping weight under control. Even if you have a genetic propensity to develop diabetes, you can still sometimes avoid it. And my number one is smoking. If you don't have to add that risk factor, don't add that risk factor. It is the worst thing that you can do for your heart, not to mention lungs and risk of cancer and all of those things. Smoking increases the risk of heart attack in a big way, and particularly for young women. Young women, the combination of smoking and oral contraceptives is a very deadly combination. It really increases their risk of thromboembolic disease and heart attack, even in a young woman. Smoking is bad for the heart in so many ways. It puts more strain on the heart. It can elevate your blood pressure. It can damage your blood vessels. It leads to more of a buildup of atherosclerosis at a more rapid rate. It causes the buildup of carbon monoxide within the blood, which blocks the delivery of oxygen to the heart. And it ages you much earlier. So if a person can quit smoking, it's a very big impact on their lives. In addition to those things, I like to ask people to focus on living healthy. I don't like to make it to say you can't eat this and you can't do this and you can't have that, because that always becomes a very negative feeling. So for me, when I present this to people, I like to keep it positive and say what you should do is start thinking about doing everything you can to make yourself as healthy as you can possibly be. Let's see how we can help to, get your weight under control, get you more active, make healthier choices in your diet, and get rid of the things that are hurting you.
Yeah. Well, Dr. Denier, we have only touched the surface. We haven't even talked about hypertension, high blood pressure. So we're going to have to find a time to get you to come back and educate the public even more than you already have. We're very have great benefit in this community to have you here. So thank you for being here, and thank you for being on the program.
Thank you so much.
Again, we've got more to talk about, so maybe we can do this another time.
Thank you so much. Thank you for having me.
Our pleasure. Well, that's our program for this week. If you have questions or comments, you can contact us at watchapptv.com. And please, again, join us next time for Health Talk here on App TV. I'm Dr. Jay Noreen.